Okay, Migraine Canada. We are a federally registered charity supporting all Canadians living with migraine and headache disorders. Our mission is to improve the lives of Canadians with migraine and other headache disorders through advocacy, awareness, education, research, and support. Please watch out for more of our webinar series this year. Feel free to join our growing community. Our website also has an advocacy page with useful tools to advocate for yourselves and your loved ones who have migraine. And our website also has a library with hacks for migraine management. And we are very excited to be collaborating during Women's Health Week 2023 with the Women's Health Coalition on this webinar. Be sure to also check out the 2 podcasts which will be launched this week. There are many obvious reasons our organizations support one another. Together, we are stronger and can improve health outcomes for women. And with that, I'm going to hand it over to Carmen to introduce the Women's Health Coalition.
Thank you, Kaylee. I also am very excited to be here and collaborating with Migraine Canada. I've been working with Dr. Elizabeth LaRue since the very start of the Women's Health Coalition because migraine affects women so much, and it affects women who are going through life changes. And it's probably the #1 complaint that we get as an organization in terms of the health system ability to support the patient experience. And so I'm excited to be here with Migraine Canada today. As it says, our mission is to create a movement to speak openly, learn and engage with purpose to address menstrual, reproductive, and sexual health for life through all the ages and stages of a woman's health journey. Our advocacy, we are an advocacy organization, and our advocacy is enabled by listening to women's stories. We're then informed by healthcare professional expertise and advanced by evidence-based recommendations to government and health system influencers. And as of this spring, we became a national organization. So working federally and in each province across Canada, addressing all elements of women's sexual, reproductive, and menstrual health. So thank you for letting me join you this evening, and I look forward to learning more about hormones and migraine.
Thank you, Carmen. Okay, so quickly before we begin, everyone, just our disclaimer that this webinar provides information and not medical advice. Please note that the information presented and discussed might not apply to your own medical situation. Always discuss medical treatments with your own healthcare provider who knows your medical history. And I've already mentioned this, but please post your questions throughout in the Q&A box. We will be answering the questions at the end of the webinar. And if there happen to be any questions that we don't answer, don't worry, we're going to be recording those and we'll be posting those questions with their answers on social in the next couple of days. This webinar will be recorded. And again, the entire webinar will be available for viewing within a day or 2. All right, Dr. Candice Todd is our presenter tonight. Dr. Todd is a general neurologist and a headache medicine specialist at the Scarborough Health Network in Toronto. She completed her residency at the University of Toronto, where she also completed her fellowship in headache medicine. Dr. Todd is interested in women's health issues and neurology, specifically pregnancy and its impacts on headache, as well as gender and racial disparities in neurological diseases. Okay, Dr. Todd, over to you.
I want to thank Migraine Canada and the Women's Coalition for allowing me to speak on this topic. Obviously, like it was mentioned, hormones and migraine are one of my favorites. I love helping women plan pregnancy. I love helping women manage migraine during pregnancy because I know a lot of women can do it successfully if we plan and we choose the right medications. And so, you know, if there's any questions about pregnancy or pregnancy planning, I'm also very open to talking about that as well. I just want to briefly talk about my disclosures, which have nothing to do with this talk, but I do give talks for pharmaceutical companies at times. So just in terms of presentation and what are the things that we're going to talk about, I first and foremost want to just give a very brief overview about migraine and the roles, the broad roles that hormones play in migraine. I'm going to focus also on menstrual migraine, and then the hot topic, which is perimenopause and menopause and migraine, and then how for those individuals who are suffering from migraine in the menopausal stage, how can you advocate and get the help that you need? And so that's hopefully what I can accomplish for you all this evening. I will say, like mentioned before, I'm not going to really get into too much detail about medications because really, as I'm sure you all can imagine, medications are very much a customized, detailed conversation between yourself and the physician. I am happy to talk, broadly about medications. And then the other thing I wanted to state is that this is largely a mixed group of individuals that are here tonight. So, people that may be in the healthcare profession and a lot of people who aren't. So I want to just keep it as relatable and digestible as possible to everybody. But if there's any more further details or questions that people have, I'm obviously happy to answer them if I can. So the first thing is, what role does hormones play in migraine? And I just wanted to dial it back a little bit and just make sure that we all kind of understand what the criteria is that physicians use to diagnose migraine. I'm going to assume that many of you on this webinar have migraine, are well versed in what migraine looks and feels like. But when you see a physician, often their job is to kind of listen to your history as best as they can and see if you meet this criteria. So is the headache one-sided? Well, I see lots of women who have migraine that do not have a one-sided headache. It has to be pulsating. It has to be severe. You have to want to lay down and rest. And then you can either have pieces of nausea or vomiting or light and sound sensitivity. And if you have all of that, then a healthcare provider should be comfortable with saying, yes, you have migraine, and here are the things that we are going to talk about. I think this is important to start off with in this talk, is because later on we're going to talk about how do you advocate for yourself? How do you get the best care for yourself? And one of those things is often taking on some of that role and, making sure that you're talking to your healthcare provider, because many, there's lots of research out there, and migraine is often underdiagnosed because many people don't bring it up to their primary care provider, or they think that there's, headaches are normal. The amount of time women come into my office and say, I've been suffering from migraine since I was 8 or 12, and I just thought it was normal. And now they're 30. That's a huge amount of disease burden, time lost to a condition that could be potentially treated. So I just wanted to put this slide up here for you all to see. Another few quick points just to kind of give a broad overview. We know that migraine has a huge genetic kind of underpin to it. We only have a couple genes that we've identified for certain types of migraines, but what I say in the office is that we think it's heritable. We think that it is inherited through the line of family members. So often in my office, I say, does your mom have headache or migraine? Does your grandmother? Do your kids? Because it's often runs pretty pervasive through a family. So there's not just a genetic or an inherited piece to migraine, but there's also a huge environmental component to that. And that's why, if you don't sleep well, you don't hydrate, you don't eat protein, that can often trigger migraine. Many of my migraine patients I call like my weather vane, because they can tell me when rain is about to come. They can definitely tell me when the seasons are changing, because they're just so acutely tuned into, we call it barometric pressure changes or pressure changes in the atmosphere. And that is a huge environmental component to migraine. The other thing I want to just touch on is that migraine is often still looked at with stereotypes and looked at as, it's pain and it's not interesting, and these individuals are just complaining. But we know that migraine is truly a brain connection dysfunction. And it's it's really overall, it causes an increased sensitivity to what I say in the slide, stimuli. And what that means is there's neuron dysfunction. The neurons are not talking to each other properly. And many migraineurs have ongoing sensitivity to external stimulus, even outside of a migraine. So what does that mean? It means that light bothers you, even if you're not in the middle of a migraine. And that's because a migraine brain is awful at filtering out information that is not important. So I don't personally have migraine. I'm able to filter out noise, light, pressure changes, because my brain is not interested in any of those things, but a migraine brain is. And so your brain is always on high alert, and you're always perceiving information or stimulus, even when you're not in the midst of a migraine, which I think is important to know. The other piece is that migraine is often present in individuals when they're younger, from an early age. And we do think that this is more obvious or more present in individuals who have a history of childhood trauma, which we're not getting into. But I will say that there's a really amazing book called The Body Keeps Score, and it's all about trauma and how we manifest it through chronic pain. And that is completely a different talk that we're not going to get into. But the point is that it's so there's a lot of factors that play into migraine. And obviously what you want to look for is a healthcare provider that's going to look at you kind of holistically and as a person, because that's really how I like to tailor my medications and my treatment plans. So we'll talk about that a little bit later, but I wanted to just set the stage for that. One of the questions that was asked of me is, how, migraine in childhood, and when does migraine first present itself? And really, migraine is actually a major cause of disability in young children. We can even see migraine in infants, although not frequently, but you can. And over to the right, you can see this kind of graph here. And on one axis is, prevalence, how many, or the frequency, or how many people have migraine, and then age on the long axis. And then blue is boys, and pink is girls. And what you can see is that it's a pretty even climb to about mid-adolescence, and then it drops down. And then obviously as hormones kick in, women kind of continue on with an increase of migraine prevalence, and boys kind of settle down. Prior to puberty, like I said, males and females, sex-wise are similar. And what I will say too, which I forgot to do my little disclaimer, is that I'm going to be talking a lot about male and female. That's based on sex, and individuals, when I refer to them as females, those are individuals with a capacity for pregnancy, or individuals who produce hormones endogenously. So when I say male and female throughout the talk, that is really what I mean. Little kids can have migraine. The criteria as a physician that I use is a little bit differently. There's a time piece, so they can have headache for 2 hours instead of 4. Little people get a lot of nausea and vomiting. They get a lot of warning prior to migraine, even a couple years earlier, where, if you have a child who's got lots of motion sickness, they're a colicky baby, some kids who sleepwalk or sleep talk, or kids who have a lot of stomach aches that we can't figure out why, that can often predate migraine by a couple years. And I often ask those questions in clinic when I am seeing little people. And then obviously, females start to kind of shoot off that curve, and we'll talk about that in the next slide. So migraine is actually 3 times more common in, like I said, biological women or females with the capacity for pregnancy than biological men. There's this whole hormone mix, which is exactly why we're having this talk. It's because we think this HPO axis is actually an abbreviation for the hypothalamus, which is a part in the brain, the pituitary, which is also a part of the brain, and the ovaries. And basically it's just a kind of a highway between the two of hormones, and the brain tells the ovaries to start producing the hormones because this young female is getting ready to be able to reproduce, basically. And so the average age of menarche, which is menses, or your first period, is about 12 and a half years old. And often that is the time when young women first start having migraine. You can also see migraine in young women with philarchy, which is breast bud development. And so that's usually around the age of 8. So when I say migraine can happen at any age, it's absolutely possible, especially if there's a strong genetic or inherited family history. But we often see migraine in young women out of anywhere from around 8 to 12, 13, 14, depending on when their menses starts. So it's really important to kind of identify that and see that as a physician, I use that as a kind of a gauge to see if I'm worried about any other causes for migraine. So if you're a kid who had their period at 12 and then has had migraine since, it sounds like that's probably a hormonally driven migraine disorder as opposed to something else that's causing or driving your migraine. We look for what we call secondary causes or other causes of migraine, like, if you come to my clinic at 30 and you're presenting with migraine, my job is to make sure that nothing else bad is happening. So tumors or strokes or anything else. But if you say to me, I've had migraine since I was 8, I'm a little less worried and I'm a little bit more confident in my diagnosis. So like I said, estrogen and migraine is a huge factor for many women, but not all women. But we know that fluctuations in sex hormones is really what's driving migraine for many people. We don't fully understand how migraine works necessarily. So it's got a variety of impacts in the brain. How pain is perceived by a person. It can cause headache, dizziness, nausea, temperature changes in mood. And if you look at all of that constellation of symptoms, that's really premenstrual symptoms, like before your period. That is a lot of, for many women, the symptoms that they're experiencing. Estrogen is really a game of balance. And what I mean by that is it's not all estrogen is good and drives migraine, and a lack of estrogen is bad, and that's also driving migraine. Estrogen can drive migraine, it can suppress migraine, it can kind of do a lot of things. And I'll talk about it a little bit more, but it's really about a hormonal soup. And the combination of the soup or the mixture is really a key to predicting what kind of symptoms you're going to have and in what stage of your life. So like I said here in the slide, it kind of has positive and negative effects in the brain. And we're still understanding, obviously, hormones and how it impacts the body. So an interesting topic that I personally like talking about, because I see so many women in my office who have menstrual migraine. And the question I was asked is, why do so many women with migraine see an increase in migraine attacks with their menstrual cycle? And I really like this slide. So the pink part shaded, we're going to ignore because that's pregnancy and we're not talking about that. So the far left and the far right, or my far left and my far right, are the kind of two periods of time that I'm going to be talking about. So when we talk about menstrual migraine, we're really focused on the menstrual cycle, obviously. There are 2 types of migraine that occur during menses or your period. One is called pure menstrual migraine. And what that basically means is that you only have migraine during your period. That's exceedingly rare. I think in my time in practice, I have 1 pure menstrual migraine patient. That is it. Some people that you talk to who are headache specialists do not think that pure menstrual migraine even exists. I think it exists, but exceedingly rare. The rest of the population is really built on what we call menstrually related migraine, which means you have worsening of your migraines during your period, but also outside of that time, you can have migraine. And what I was putting here below is there was a study that was done out of the Netherlands, and she had collected 692 patients and she had surveyed them, and only 2 actually had pure menstrual migraine. So you can see that that's exceedingly rare, and it's not something that we typically encounter in practice. Menstrual migraine is a migraine that typically does not have aura. And what I'll explain aura is, for those of you who do not know, that's typically a visual disturbance. Sometimes people describe it as a white blob that comes into their field of vision and kind of slowly travels across. Some people get static or snow. Some people get zigzag lines or kaleidoscope. It can really be a lot of things to different people. Some people will even get numbness or tingling in their face, around their mouth, and their arm. And usually aura happens anywhere from 5 to 60 minutes prior to your migraine or at the same time. That's what we call an aura. The reason why women who have menstrual migraine don't have aura, which I'll talk about, is because we think menstrual migraine is really a cause of estrogen loss. So estrogen, if I can go back, estrogen is kind of this blue line. So right before you're about to get your period, estrogen drops, and that is what's driving menstrually related migraine. We know that high estrogen can cause aura, and we know that, like I just said, menstruation or menstrually related migraine is a lack of estrogen. So these individuals get really, really bad migraines, but they don't get the visual disturbance that they may get outside of their period. The rule with menstrual migraine is that it has to happen at least 2 out of every 3 cycles that a woman has. And the key for menstrual migraine is that typically the migraine starts to build in intensity anywhere from 2 to 3 days prior to your cycle starting. So many people say at the start of when they're getting their premenstrual symptoms, fatigue, kind of just general malaise, irritable, that kind of thing, then the migraine will actually start, and then can actually carry on into the first couple days of their period, and then should kind of peter off. I will say that many women will get that kind of a couple days before, a couple days during, and then it'll stop, and then they'll actually get a flux of migraine towards the end of their cycle. We actually do not think that that is estrogen related. We actually think that is iron deficiency related, because as you can imagine, you have blood now for X amount of days, and that headache is actually an iron deficiency headache and not necessarily a hormonally driven headache. And so typically I will say that menstrual migraine, pure menstrual or menstrually related, whichever one you think you have, is often very challenging for a physician, even a headache specialist, to treat. And that's because ideally the best way to treat a menstrual migraine is to treat the hormones to kind of stabilize and not cause this fluctuation in estrogen. So if an individual is severely debilitated by menstrual migraines, I often will do one of a few things. One, I'll ask them to talk to their gynecologist to see if an oral contraceptive pill or progesterone only pill or an IUD or some way to kind of smooth out the fluctuations that a woman is getting during their period. The other thing is, if you are a woman who has very routine, clockwork kind of menstruation and migraine, then I can do something. And I said I wasn't going to talk about drugs, and I'm not going to talk about drugs, but we can do something called a mini prophylaxis, where I actually treat you during the course of your period with certain medications. And sometimes I even use supplements like magnesium, which has great evidence in headache, to try and get ahead and try and help you out during that period of time that's so debilitating for you. So that's kind of the gist of menstrual migraine in a nutshell. The next topic, which I think is the topic that is maybe most interesting to many people, and maybe that's why they joined this webinar, is really perimenopause and menopause. And I find that this is also an exceedingly challenging migraine to treat. And any perimenopausal woman that comes into my office, always first question asked me is my headache going to get worse? Is my migraine going to get worse? Is it going to be over when when I'm out of menopause? And I'll talk about that because there's no real easy answer. So now we're kind of on to the far, right of the screen. In terms of all of a sudden your estrogen is, dipping down, and then you get all these, you can see this kind of squiggly lines where it's just your estrogen is all over the place. And you also have a hormone called progesterone, which is also kind of petering off, and eventually you go down to nothing, and that is menopause. So menopause, for those of you who do not know, is basically divided into 3 stages. So premenopause, in a nutshell, is your reproductive years. Those are the years that you are supposed to be reproducing. So there's very little fluctuation in your period. It's supposed to be very little fluctuation in your period around that time. So your cycle doesn't veer too much more than a week. You've had a period within the last 12 months, or you haven't missed more than one period in the last 12 months. And then the time that most people are interested in is this perimenopausal period. So typically the age that perimenopause starts is anywhere from 45 to 55 years old. And I typically say, ask your mother or your grandmother or your sister who's older what age they went through menopause. And that's usually what age you go through menopause. But obviously that can fluctuate. The perimenopause stage can last quite a long time, and you kind of have two phases to perimenopause. You have an early and a late phase. And so basically the gist of perimenopause is that the cycle can vary greater than a week. Your period can be anywhere from 2 to 12 months in space, and you've missed more than 2 periods in the last year. That's kind of the perimenopausal stage. And then the last but not least is menopause. And the overall gist of this period or this time in your life is that there's no menstrual periods for greater than a year. And then I'm getting back to that kind of hormonal soup that we talked about, whereas the mixture of estrogen and progesterone is fluctuating. But basically at the time you hit menopause, you should basically have low levels of estrogen. There's less of this kind of fluctuation that we see in the curves that I showed you before. And your progesterone is basically down to nothing at that point. That's the menopausal or postmenopausal phase. So the question is, does migraine typically get better or worse during the later years of a woman's life? And I really like this question, but it's not an easy question. It's not a yes or no answer. So there was a really great study done by the American Migraine Prevalence and Prevention Study, which is kind of a mouthful, but basically they looked at a bunch of women who already have migraine. So I'll preface that this study was done in women who've already gone into the menopausal period with migraine. And so there's often just, to be honest, it's often worse. It's often worse during the perimenopausal period. And that those years when you're transitioning into menopause are not always amazing years, I will have to say. But I will say that is for a woman who has menopause or has migraine that is really linked to hormones. They're kind of the classic migraine that started at their, around their period. It's kind of been persistent throughout their lifetime. They've got worsening during their period. That's probably 9 times out of 10, their migraine is not going to be great during the perimenopausal period. The other really interesting piece that I find is the type of menopause is really important to note. So migraines are less or 40% less often or present after natural menopause. So what does natural menopause mean? It means exactly what you think. So spontaneous menopause that is induced is not a natural menopause. Surgically induced menopause is not obviously a natural menopause. And so that can often be associated with severe intensification or worsening of migraine if you are unfortunately in those situations where you have a not natural menopause. So whenever a woman's ovaries are removed and we're not adding estrogen back into the woman's system, that's usually when an individual will have more frequent and more disabling migraines or headaches. It's around that time. The study that we looked at, or that they looked at all these women, I think there was over 20,000 women that they looked at, preventative medications were used the most in the late menopausal stage. So why does that even matter? Is because as a headache physician, as a neurologist, I typically choose preventative medications, which means a daily medication in individuals who have more than 15 days a month of headache. So this line is telling me that headache was extremely more frequent in the perimenopausal stage, in the late stage in women. And so kind of the short answer is that yes, perimenopause is not a great time for migraine, but we hope that in the end, throughout menopause, that things get better for many women. I will add, and I think I mentioned this before, perimenopause and migraine is, worse in women who have a history of menstrually related migraine, whether that's for migraine around menses. So whether that's your, the rare bird that is the pure menstrual migraine or menstrually related migraine. I kind of highlighted this excerpt from the study because I thought it was really helpful, and I want to talk about it a little bit more. So during menopause, migraine prevalence, or the presentation of migraine, decreases overall. So that's, I think, a bright light for many people. But like anything, it really depends on what you look like going into menopause and perimenopause. So for those who didn't have high frequency migraine or headaches going into menopause, many women lost their migraine characteristics. So they weren't, hiding in a dark, quiet room. Light wasn't constantly irritating them and bothering them. They may have had, what we call tension type headache. It's, it's mild, it's annoying. You don't have to go to the emergency department. You can handle using, Advil or whatever. It's a manageable headache. And so that is what we see most often in women with low frequency migraine or low frequency headache. Some women can have a higher frequency of headaches with a decrease in migraine. And I find that those are individuals who went into the perimenopausal or menopausal stage with lots of migraine. I definitely have women who have like 2-3 migraines in a week. And so those individuals, when they enter into perimenopause when they enter into menopause, may have less migraine, still a lot of headache. I'm not saying it's going to be perfect. They still may have a lot of headache, but the really debilitating migraines are hopefully a lot less frequent. And that is in the menopausal range. So the moral of the story is, I can't with confidence predict, what a woman is going to look like once they reach menopause. And I'm pretty upfront with my perimenopausal and menopausal patients. Each individual, as I'm sure you all know, are extremely unique. And so I like to provide some hope, but I'd like to be realistic and just, we have to kind of watch and wait and see what happens, to be honest. So the other question that I was asked is it common for menopause or perimenopause to trigger new onset migraine? That's also a very not an easy question, because migraine can happen literally at any age. There was actually a study that was put out that I kind of quoted here. There's kind of actually 2 peaks to migraine. So, migraine is typically seen in the adolescent years, like I talked about, but there's like a cluster of women who present with migraine around the 18 to 44-year-old range, kind of dies out a little bit and then can kind of pick up. So actually there's not a small group of or population of individuals who start to actually present with migraine in their 60s. And so those individuals, I will preface and say that they're probably not hormonally linked, I don't think, but it's absolutely not outside of the realm of normal to have your first migraine at the age of 60. Migraine is obviously more active prior to the age of 50. Perimenopause increases other condition, increases other medical, we call them comorbid, other things, other medical health issues often arise around the perimenopausal time. So if you were someone who came into my office and said, all my life I've had, maybe 2 headaches a week, 1 headache a week, and then all of a sudden, now that I'm in the perimenopausal stage, I am just like flooded with migraine. I am debilitated. I cannot function. But I was never a person who had menstrually related migraines. Like migraines did not, become more frequent around my period. Hormones were never an issue for me. And what I would say is during the perimenopausal reach at the time, often mood is impacted. So anxiety and depression is a little bit worse around perimenopause. Sleep, you've got all these night sweats and hot flashes. You can't sleep, so you don't get deep restorative sleep. And so all of that can contribute to worsening of migraine during that time. So you could have been grumbling along with a few headaches, and then have a surge of headache around your perimenopausal period of time. As a physician, if you come to my office and you have your first presentation of migraine after the age of 50, it is my job to make sure that nothing else is happening. So I talked really quickly about secondary headaches, or what that means is other causes of headache. So whether that is a tumor or a stroke, or, I make sure that there's no clots in your blood vessels in your brain. And my job is to make sure that there's not another medical condition that should be treated before we just rest and say, this is migraine, let's move on to the treatment phase, if that makes sense. So I would say, if you're over 50 and you've been grumbling along through your life with just 1 or 2 headaches that seem very manageable, and then all of a sudden in your 50s, you are having the worst headaches of your life and you're debilitated, I wouldn't be so quick to say, nah, it's nothing. I would obviously present to your healthcare provider and talk to them and kind of make sure that everything is okay and there's nothing else being missed. What is hormone replacement and who is it best suited for, and is it safe? The short answer is I don't prescribe HRT or hormone replacement therapy. I can give you my opinion on HRT from a neurologist perspective and a headache medicine perspective, and my thoughts about that. But obviously the risks and the benefits of HRT are really something that needs to be discussed with your gynecologist or your primary care provider. So that's my little disclaimer. For those of you who don't know what hormone replacement therapy is, it's really, the goal is to supplement or add back hormones that are lost during the menopausal transition, the perimenopausal period. It's trying to create a balanced hormonal soup, sort of speak. So like I said, your hormones are all over the place. They're fluctuating day to day, week to week. And the goal of HRT is just to keep everything as smooth as possible. The red is, why don't we want to use hormone replacement therapy? And so we don't use hormone replacement therapy in anyone who has a history of breast cancer, and anyone who has I put CHD, which is heart disease, basically anyone who's ever had a stroke in the blood vessels in the legs or in the lungs or in the brain. Anyone who has any liver issues, we don't use HRT. And anyone who's had vaginal bleeding that can't be explained would be like a hard no. When can you use HRT? It's actually just a very curated group of women, really. So I personally would probably not consider hormone replacement therapy for anyone who's not, exceptionally healthy. And what I mean is that there's no high blood pressure, there's no diabetes, there's nothing. You are not on a medication, you're not even, maybe you're taking supplements, but otherwise you are the pillar of health. The max you can use HRT is about 5 years, and you can absolutely hard no be taking it beyond the age of 60. So you can see that it's a very curated group of individuals that would actually meet the criteria for hormone replacement therapy. So what does it mean for migraine, which is why you're all here? So hormone replacement therapy, this is kind of a busy slide, but I wanted to make sure we got it all in. So it has a kind of a variable impact on migraine. So what does that mean? It may actually worsen migraine in women who already have migraine, or it actually has been known to induce migraine in women without a history of migraine. And that's because estrogen, like we know, isn't as easy as estrogen withdrawal causes migraine, or estrogen increase causes migraine. It's this net effect that I was talking about. So too much estrogen can actually cause migraine with that visual disturbance that I was talking about. And so worsening of migraine in menopause may be a predictor of you not doing well on hormone replacement therapy. So I'll say that again. If your migraines get worse during the perimenopausal the perimenopausal period of your life, you may not be the best person to be on hormone replacement therapy. And in fact, there's a high likelihood that you would not do well on it from a migraine perspective. There are some reasons why HRT therapy could be beneficial. So some studies suggest that the non-oral routes of estrogen could be helpful, like the patch or the gels. And that's because we think that there's maybe a steady stream of estrogen being delivered, and it's kind of helping to control the fluctuations that you're getting during menopause. But again, that's, very person dependent, patient dependent. From a neurologist point of view, from a stroke perspective, we think that there is an increased risk of stroke in individuals with hormone replacement therapy, even if you didn't have a prior history of stroke in the past. And I'm happy to talk about that more in detail. But I personally do not think that HRT therapy is something to be taken lightly, and you'd really have to have a really engaged conversation between, if you have a neurologist or a primary care provider and your gynecologist, about, is that the right treatment for you? Okay, and so the other thing is, seeking healthcare practitioners and advocacy. I think first and foremost, being a part of these webinars and forming yourself is like, it's such a huge piece to that. How do you advocate for yourself? Ideally, you want to find someone that's, willing to listen to you, and that can often be really challenging. Like I said before, the other piece is that I've seen countless numbers of women who say, I get a migraine or a headache 1 or 2 times a week. That's normal. And the first thing I say is that is absolutely not normal. I do not get a headache 1 or 2 times a week. I don't even get a headache once a week. So I think being comfortable and advocating for yourself, talking to your primary care provider about migraine or headaches in general, and just making sure that everything is okay, that your healthcare professional is not worried about your headaches, and that it's not something to be overlooked, because it can absolutely be treated. The other thing is, if you're, for whatever reason, don't think that you're getting the answers that you want to get from your primary care provider, there are neurologists. All neurologists are trained in headache at one point in our residency training, and then you can ask for a migraine specialist if there's one in your area. And then you can go deeper and find a migraine specialist who specializes in women's issues and headache, like myself, which is not as easily read as available as what we'd like it to be. But obviously, you can kind of ask around, talk to people, and at least try and seek out and keep looking for someone that's willing to answer your questions and provide help. I think would be the best thing. I also think that it's really important to talk to other people, because you'd be surprised at how many individuals, neighbors, friends, coworkers actually have migraine, and they're often a wealth of knowledge and information. The question is, what type of practitioner is most suitable for managing hormonal migraine? That's not really an easy question. I think, like I said, you just want someone who's willing to listen. And if they don't know the answer, that they're willing to find the answer for you. And obviously, like I said, going and informing yourself, going to Migraine Canada, going to other resources. I've named a couple here. The American Migraine Foundation are all very helpful to provide some resources, literature, things for you to read, resources for you to utilize. The question of, how do you involve multiple providers to work together for you? I have a lot of patients that say, I see a gynecologist. Can you copy your note to my gynecologist? Absolutely. Then I don't make more work for the family physician. I just go directly to the gynecologist. You just really need to communicate and kind of talk about what your expectations are or what your goals are. Don't ever be afraid to ask. In terms of treatment, we're not going to get into it, obviously, but there's a lot of options for treatment right now. It is like the best time for me to be a headache specialist, because I've got all these well, I have all these drugs and options to use in my migraine patients. And whether that's oral, injectables, like once monthly, once every 4 months, this is the time to really talk to your primary care provider, your neurologist, your headache specialist about medications and options. I think that would be the best thing. And the last point I want to say is, you know yourself, you know what's normal and you know what's not normal for you. And so, like I mentioned before, many patients don't talk to their primary care provider. On the flip side, I'm trying in the background, giving talks to other, family doctors and people to say, listen, migraine is just as prevalent or present as high blood pressure and diabetes, and we've got to start screening individuals for migraine more. So there's kind of advocacy that needs to be done in the back end. And there's also kind of more advocacy that I'm trying to encourage my patients to tell friends, tell loved ones that there's really an option and a treatment path for many people. Why is advocacy so important to improve and advance treatment in migraine? Like I said before, there's just so much stigma around migraine still, and it's very sad, to be honest. I think that it's still, like I said, underreported. It's not a particularly like attractive and sexy disease. It doesn't get a lot of donor money. It doesn't get a lot of, advertising. And that's why Migraine Canada and, other programs are so important to kind of get the word out and make people feel a lot less isolated. Because I do see that a lot, or I hear that a lot, that women with migraine or people with migraine feel isolated and they feel like they're not understood. And that's why advocating for yourself, getting out there, talking about migraine with friends and loved ones and coworkers is really important. On my end, I'm trying to, facilitate or try and encourage more knowledge around migraine. So whether that's I'm speaking to family physicians or, gynecologists and talking about menstrual related migraine or migraine during pregnancy, that's super important, and I'm trying to work on that in the back end. The other piece is we just need more headache specialists. We train two headache specialists in the country each year. That's not very many of us, and we're all densely populated in the Toronto area, to be honest. Most of us trained at Women's College, which is a headache center, and we all scattered, around there. But we need more headache trained physicians. And so we're trying to work on that, but that's going to be a slow process. And then the last piece is we just need to keep going with new advances in the field. Like I said, there's a lot of new medications that we've been waiting and hoping and wishing for that have finally come across the border. And we just need, more advancement, more research to be completed, and, more options for people. We've had more options though for migraine than we ever did in the last 10 years. So it is an exciting time, not to have migraine, but it's an exciting time to treat migraine, because I feel like there's so many options that I can customize for patients. And with that, I thank you.